We have 600 delegates here for human milk and lactation. If you go to a neurologist conference, you might see thousands of delegates. People studying the adult human brain, for the most part, and problems, things that break in the human brain. And yet, as Professor Storm will tell you, Professor Storm, that brain develops and is programmed to guide us through our lives in the womb and in the first 2 years of life. And human milk has been proven to deliver elements that help that brain develop optimally, elements that cannot be replicated by any science that we currently know. So if some of those neurologists devoted themselves to understanding what feeds the brain and gives us the best possible start in life, we wouldn't need to spend so much money figuring out how to fix the brain when it breaks later in life. This is why Patricia Johnson today, Professor Johnson, will tell us that she believes that breastfeeding is a primary public health intervention on the level of vaccines. That's a powerful statement. Just as powerful was a statement made by Keith Hansen 2 years ago, when he said that if breastfeeding didn't already exist, the person who invented it would deserve a dual Nobel Prize in medicine and economics. That's why we are really proud to call ourselves the world's leading advocates and partners for human milk. It's not exotic to us. It's something that impacts us, whether we're breastfed or not, as members of society every day of our lives. And that's why we bring together the world's leading specialists in this field to share their knowledge, to advance healthcare practices around the world, and so that we can help support mothers who want to breastfeed and help more babies get the best possible start in life. And so now I would like to introduce our panel of experts. Beginning with Professor Bruce German, Director of the Food and Health Institute at the University of California, Davis. His seminal research has helped us to understand why mother's milk has evolved to be this unique nutrition for babies. Professor Laurence Storm, Professor of Pediatrics and Head of Neonatology at Lille University Hospital, has spearheaded a training program in France around those first 1,000 days of life in the womb and then 2 years after, so that he can help caregivers to understand how they can help babies and mothers prevent disease. Professor Tricia Johnson, economist in health systems management at Rush University, will show us how a tiny investment at that crucial moment early in life can reap massive economic rewards as well as health rewards, and not just for babies, but for all of society. Dr. Alicia Jane Twigger, it's a fascinating study, creating mini breasts in the lab with the aim of getting them to lactate to understand how breast cells differentiate and become abnormal and result in low milk production or breast cancer. Professor Megan Azad, Professor of Pediatrics at the University of Manitoba in Canada, has led a first-of-its-kind study in Canada to study the impact of mother's milk on asthma long-term. And she will share how she has revealed through this study that you could reduce asthma rates by as much as 40% through exclusive breastfeeding. Professor Donna Geddes directs the Hartman Human Lactation Research Group. She discovered in 2005, for the first time, the real internal anatomy of the lactating breast. That's how young this science is. Women's health in general is a neglected topic. This is even more behind. She discovered this, and today she's going to talk about tongue tie and the controversial treatment that's applied to try to help tongue-tied infants breastfeed. Professor Thomas Hale, excuse me, Losing my papers. Professor of Pediatrics at Texas Tech University School of Medicine, and the world's leading expert on medicine and breast milk. Today he's going to talk about what happens when a mother smokes marijuana and it gets into the breast milk. And definitely not least, today, Professor Paula Meyer, who has dedicated her professional life to human milk and lactation. Since 1975, she's been working in this field. She's professor of pediatrics and nursing at Rush University Medical Center, and today she's going to talk about a new best practice standard to help support mothers to lactate in the NICU, the neonatal intensive unit. And so, now I will go back to you, Professor German, and ask you about a very intriguing quote. So we've had some journalist requests coming in, and you said something fascinating to one of the journalists. You said that mother's milk is living and dynamic, I'm going to paraphrase now, and constantly adapting to the environment and the needs of the infant. Can you explain why that is so important for the health of infants?
Oh, that's a wonderful question. We think that the evolutionary history of lactation is the perfect model for nourishment in the broadest sense. And the way milk changes according to the demands and developing infant is quite instructive about how milk makes babies healthier, not just long term, but minute by minute. We didn't even have the tools to be able to investigate milk in this time dimension. But now we've developed those, and the more we look at milk, the more we realize that it's personal, it's a direct communication from mother to her infant, it's alive, there are living entities in milk that are helping the baby, and it's constantly changing. And it's that dynamic aspect that we haven't appreciated. In fact, the term milk doesn't really do justice to how complex the process of nourishment is. Because milk implies that there's one thing. But if it's changing all the time, then that's quite different. So milk is teaching us far more about how to nourish everybody than just babies.
It's not your milk from the grocery store.
Right.
Right. Okay. Professor Storm, your 1,000-day program basically elevates the first 2 years of life to the same level of importance as the development in the womb. Is that fair to say?
Je me permets de répondre en français. Effectivement.
I will answer in French. Yes, the first 1,000 days of life are a very important period for the future. The first 1,000 days, that's a period from the day of fertilization until the age of 2. And during that period, we know that this program, that is the future diseases we're talking about a lot today, which is a real public health issue, most of the chronic diseases in adults, that is allergies, obesity, diabetes, degenerative pathologies like Alzheimer's, cancer, problems with the prostate, etc. They don't only appear at the age of 50, 60, or 70. They are programmed right during the first 1,000 days, and even before that. It's during that period that the germs of these future diseases are going to be instilled in the baby. And these germs are set up by the environmental factors. It's a bit our genes, a bit genetic, but most of these problems are programmed during the neonatal period by the environment. And the strong message we'd like to convey today is that we must preserve this first 1,000 days, that is the pregnant woman, the breastfeeding woman, until the age of 2, because this really impacts the future health. Breastfeeding does illustrate this concept. Breastfeeding is a postnatal intervention during this 1,000-day period, which lasts for a few months. And we know that this intervention will have a huge impact on the future of the baby. It will reduce a certain number of these chronic diseases I talked about, and we'll be talking about them again this afternoon.
Professor Johnson, you're presenting breastfeeding as a primary public health intervention as important as vaccines. Is that right? Correct?
That is correct.
It would seem to imply that we need to consider the impact of breastfeeding at a national policy level. What do you say about that?
So there is a growing body of evidence from the economic perspective that early life interventions improve capabilities not only through childhood but through adulthood. So if we think about these primary public health interventions making a difference not just in the first 2 years or through childhood, investing in breastfeeding, you really can't have an earlier intervention than breastfeeding for an infant. And if that improves neurocognitive development, decreases healthcare needs, the benefits accumulate over not just childhood, but over the whole adulthood.
That's decisive. Dr. Twigger, you want to get mini breasts to lactate in the Petri dish or, whatever it is. So can you explain to us what a mini breast is and how that's going to help you determine how breast cells become abnormal?
So what we're trying to do is understand lactation on a cellular level. And it's quite surprising that we don't already know how a breast is actually making milk and what sort of cells are contributing to the massive changes that are happening during pregnancy and causing lactation. So mini breasts, or as we would like to call them, mammary organoids, are these tiny structures that we can grow in culture. They're derived from a single cell. And actually their structure is very similar to what we find in the breast. Now, when you think of the term mini breast, you might think a huge mini breast in culture, but actually they're tiny little specks, almost like a piece of sand. You can still see them. And when we look under the microscope, we can then understand how the cells are organized. We can study, hopefully one day, how the milk is being produced by making the model functional. Then really understand lactation. So that's our goal, is to simulate what's happening in the adult breast during lactation in culture.
Thank you. Professor Azad, this is fascinating that mother's milk can prevent a disease that has no cure. That 235 million people and rising every year are suffering from around the world. Can you explain to us why this is a first of its kind study and what that means in terms of the authoritative nature of the research?
Yeah, so I work with an amazing study in Canada called the CHILD Study, or the Canadian Healthy Infant Longitudinal Development Study. This study was specifically designed to look at the origins of asthma, the developmental origins of asthma. So we heard from my colleague en français that the first 1,000 days are so important to the establishment of chronic diseases, and that includes asthma. So asthma is the most common chronic disease in children, and as you mentioned, there is no cure. So to address this enormous problem, we really have to look at prevention. And so I work with a whole team of researchers across Canada really trying to address this problem. As we heard, there's a little bit of genetics, so asthma runs in families. We know our genes are involved. But at the same time, asthma has skyrocketed in the last generation. So there are so many more children, and those children become adults who suffer from asthma. We know the genes are involved, but it's really got to be something in our environment that's triggered this epidemic. And so we're looking very broadly at the environment. That includes things like air pollution, but it also includes nutrition and what we're eating and what we're feeding our babies. And so my role in this really large study has focused initially on the gut microbiome or gut bacteria. We're learning that these are so important for the development of chronic diseases. And so my research showed that, first of all, we could see very early in life that infants with a different mixture of gut bacteria were more at risk for asthma. And so then we said, well, why do they have this different mixture of gut bacteria? And one of the things we find making a huge difference is what we feed the babies. And so babies who are breastfed have a very different mixture of gut bacteria. And so that's been my focus lately, is to really understand that concept. And so firstly, what we see is that babies in the child study who are exclusively breastfed have a massively reduced risk of wheezing in the first year of life. And we know that wheezing is a strong risk factor for asthma later on. So I initially focused on that first period of infancy, but these children, we continue to follow them. There's 3,500 all across Canada participating in our study, and they've just turned 5 and they're still growing up. So we're going to learn so much more about which of these babies went on to develop asthma, and tracing that back to whether they were breastfed or not. And we're able to go into a lot more detail than just that yes or no question, which is really key about this study. So a lot of research around the world about breastfeeding has simply asked mothers, did you breastfeed your baby, yes or no? But we're digging a lot deeper into that to see how long have they breastfed, how exclusively, what kind of foods have they introduced and when. And then also the most exciting part, I think, of the study is that we actually collected samples of breast milk from all these mothers. And so we're now able to look at that milk and see what in the milk, this dynamic tissue, is important for asthma. So we're studying the microbes in the milk. We're only recently realizing that actually milk isn't sterile. It contains live microbes, and these are important. We're also looking at something called oligosaccharides, which are fascinating. These are complex carbohydrates in milk that babies actually don't digest. So for many years, people kind of ignored them, thinking they're probably not important if the babies don't digest them. But we now realize that the gut bacteria are digesting those oligosaccharides, so they're also really important. We're studying that. As well as other things, so hormones and fatty acids. Milk is amazing. It's not just one thing. It's containing all these interesting components, and they're not the same in every mom. That's what's fascinating, right? They're different in different women, depending on many, many factors that we've captured in the child study. So we're able to study that and link it all back to asthma, but also other chronic diseases that we're following in this group of families and children.
Wow. I can't wait to hear more. Professor Geddes, tongue tie. So first, could you explain to us what tongue tie is exactly, and why this, although the tongue tie rates are rising, the treatment for tongue tie is rising even faster than the rates of tongue tie. So that's a bit odd, isn't it? And then why do you think that this treatment needs to be reconsidered now based on your research?
Thank you, Olivia. So first up, there's no globally agreed definition of tongue tie, which makes comparison of the literature difficult. It makes it difficult for researchers to actually grade a tongue tie and then do research. So basically, about 15 years ago when we did our first study, we were cutting anterior tongue ties. So somebody might have one in the room. If you can't poke your tongue out and there's a tight frenulum, the tissue under the tongue, that is very obvious and restricts movement, that was called an anterior tongue tie. And then in the past 10 years, posterior tongue ties have become into vogue. So in the absence of an anterior tongue tie, if you dig a little deeper and look for the frenulum under the tongue, it may be tight and restricted. And that's classed as a tongue tie if it's associated with breastfeeding problems. So not much study has been done on the posterior tongue tie, and that appears to be, from the studies, what most frenotomies are being performed on. So a frenotomy is recommended as a simple solution to the tongue tie to improve breastfeeding issues, right? So it's a surgical procedure. What's happening though, as Olivia mentioned, is with our awareness that it seems to improve or reduce pain during breastfeeding, and mothers feel that it improves their breastfeeding, despite the evidence being graded as low evidence, people are diagnosing tongue tie much more. So we have this huge increase of diagnosis, and along with that, we're having a huge increase in frenotomy. in our state alone, in Australia, it's risen in the last 10 years by 550%. And that is echoed throughout the world. That doesn't even include the dentists that are lasering tongue ties, so it's an underestimation. So many babies are undergoing frenotomy with deep cuts, and therefore we're seeing more complications from the procedure. What we did in our most recent study, which we have the first results, is we compared babies before and after frenotomy with a control group prospectively. So what we found was, astoundingly, 2/3 of the babies that were pre-frenotomy, scheduled for frenotomy, were not transferring enough milk from the breast. You might expect this from this group, but the next thing we found was that half the mothers weren't producing enough milk for their babies. And Alicia alluded to this, that low milk supply is not well understood, and it's becoming more and more prevalent as we move on and evolve. So what happened next was we looked at pain as well. We looked at the strength of the suction of the baby, thinking that if that's strong, that could be causing the pain. We looked at the babies post-frenotomy, and we're awfully surprised to see that the babies did not improve. They did not transfer more milk, and the mothers overall did not produce enough milk for their babies. So the procedure did not resolve the feeding issue underlying the tongue tie, which was the transfer of milk from the breast. However, mothers experienced less pain and they perceived things to be better. So we really need to reconsider which babies undergo frenotomy so that we can be more successful and improve breastfeeding rates.
Thank you. Professor Hale, now this is a topic that fascinates a lot of journalists, and I think it's because marijuana or cannabis is being legalized in various parts of the world, especially in the US, and not just for medicinal use, but also for recreational use. That probably means that more people in general and more mothers are going to think, I could have a little marijuana now and then and it won't do any harm. So your research measures the marijuana in breast milk and gives us some insights into what the impact could actually be. Would you share some of that with us?
Yes. Despite the fact that marijuana or cannabis has been around for 6,000 years, we really didn't know how it worked until about 15 years ago when the receptor sites, the CB1 and CB2 receptor sites, were discovered. And the problem, particularly in perinatal medicine, is that it's quite often used by pregnant mothers. We assume somewhere around between 5 and 15% of mothers use it for nausea and vomiting of pregnancy. And thereon after that, they also use it while breastfeeding. The data, we've only had 2 old studies that were done many years ago that were unfortunately not too accurate. And so there was an enormous need in the last few years to get some really good data on the transmission of marijuana into human milk and how much the baby absorbs. We've just done that through a rather circuitous pathway, because the problem with studying marijuana is that despite that it's legal for certain kinds of uses, it's not necessarily legal for a pregnant mother or a breastfeeding mother because they're exposing an infant. So we had to go through a rather circuitous route to figure out a way that we could study a breastfeeding mother, and we did that. I actually had to leave the state of Texas and go to Colorado to do that, where it's legal. And so we're getting ready to publish that new data, and the data is good, and it's going to be good for the whole field, I think, because we finally can advise mothers that the dose that the infant may receive is really quite low. And so it should be helpful. I'm not suggesting in any way that marijuana is a good idea to use in a pregnant or breastfeeding mother, not at all. But there's a lot of hysteria associated with many drugs. That hysteria is often wrong. The breast milk compartment in a human being is just marvelous, and it's incredibly intelligent, and it knows how to keep certain drugs out of breast milk, and it does that often. And so we hope to bring some new knowledge to this field, not only about cannabis, but other components that may be present in human milk that are associated with the endocannabinoid system that's normal in human.
Okay, thank you. And now, Professor Meyer, you are going to present a new standard for lactation care. And this is based on the Rush University Mother's Milk Club, is that right? So as I understand it, there are 7 hurdles to lactation care in the NICU and to successful breastfeeding. And you have found a way to overcome all of those hurdles with pretty minimal investment. Would you like to share about that?
So I'll do my best. So I actually had a large human milk research team as well as a clinical team. And our research is basically translational, meaning that it has direct clinical application. And for the last several years, our funded team has looked at outcomes and cost of mother's own milk feeding for babies that are born very low birth weight. And these are babies that are born under 1,500 grams and typically about under 32, 33 weeks. So as a part of our research, that was a prospective cohort study, we found a dose-response relationship between the amount of mother's own milk that infants received over different periods of time in the newborn intensive care unit, and a reduction in the risk of many of the complications of prematurity. Now, these include serious bowel disease of necrotizing enterocolitis, infections or sepsis, chronic lung disease, and retinopathy of prematurity. And then we also found a reduction in the risk of neurodevelopmental problems when babies receive what we call high dose and long exposure to mother's own milk in the newborn intensive care unit. And one of the things, and Dr. Johnson is a member of our team, and one of the things we have studied in relation to these complications of prematurity is the cost and the potential cost savings with human milk. So with those data that show that mother's own milk, and I would clarify here, this is mother's own milk, because donor human milk does not have those same outcomes. It's often looked at as a replacement for mother's own milk when mother's own milk isn't available. And as a short-term replacement, it reduces necrotizing enterocolitis, but it has no effect on any of the other complications. So the conclusion is that babies need their mother's own milk. But mothers who have babies who are born very low birth weight and cared for in newborn intensive care unit have a number of barriers or hurdles, as you call it, to producing a lot of milk over a long exposure period. So our translational team, because we studied not only the outcomes and the costs, but our translational team over the years has examined what are the barriers that mothers experience to being able to provide high-dose, long-exposure milk. So I will be talking about those. In particular, they include the fact that even though the data are compelling and really very conclusive about the outcomes of human milk, mother's own milk in this population, because the mothers deliver prematurely, many healthcare providers feel that they're pushing the mothers or they're pressuring them by telling them how important their milk is. The second challenge that mothers experience, that's a large one, is that they are what we call breast pump dependent. The babies aren't able to remove the milk because they're too small and too sick. So the mothers must have technology. They must be able to substitute with the breast pump what the baby would do, oftentimes for 2.5, 3 months. So that is a challenge, and it's an area that's understudied as well. And then the whole issue of peer support, because not only are the mothers experiencing a number of these physical hurdles, but they have a baby who has one day in the NICU that the baby's doing well, and the next day the baby might be doing very badly. And we've instituted a program where the main lactation care providers in our intensive care unit are mothers who have had their babies in our intensive care unit. They aren't volunteers, they're paid. And then the final thing I would just mention is that babies in the NICU and the feeding of their milk require technology. So it's a field that's completely different from mothers breastfeeding healthy full-term babies. So sometimes we have to modify the milk. Sometimes we have to modify how we feed the milk to the baby. It requires an investment of freezers to house the milk in the NICU. So one of those barriers as well is economic, and Dr. Johnson will be talking about that. But my focus will be on how we overcome those barriers with examples from our Rush Mother's Milk Club program, where 98% of the babies receive their own mother's milk.
Thank you. I have a lot of questions myself, but I want to give the opportunity to the journalists who are here especially to ask their questions, and also the journalists who are watching the live stream online, because there is a live chat for this as well. So let's go to the questions now. Yes. Who would like to ask a question first of any of the speakers? Thank you. Don't be shy. Also, everybody should probably have their translators on, because I think we do have a number of French journalists here, and you're very welcome to speak French. When you ask your question, the speakers will be able to understand you through their headphones. Yes?
Hello, I have a question for Professor Hale. Hello, Professor Hale. I wanted to know what are the advantages for mothers of using marijuana during pregnancy. I didn't really understand why do they use marijuana while they are pregnant or after, while they are breastfeeding.
That's a good question. Mothers use marijuana for a variety of reasons, many of them treat anxiety disorders, some of them treating chronic pain disorders. I'd say the majority, although I don't know this for certain, but the majority probably use it for nausea and vomiting of pregnancy is the reason they use it while they're pregnant. But despite the fact that it's illegal and there's a lot of hysteria associated with marijuana, we can't deny the fact that many of the clinical aspects and the clinical uses of marijuana are really quite good. And so I think in the next 2 or 3 decades, what we're going to find is that we're using marijuana or marijuana-like products that interact at the cannabinoid system in the human body to treat a lot of different kinds of syndromes. So it's an entirely new area. It's been impeded by the legality and the legal issues. I don't think it's a particularly good idea to use in pregnancy. The animal model studies that have been done with marijuana in pregnancy show that it to be highly teratogenic, cause all kinds of birth defects. But at the same time, those of us that work in perinatal pharmacology know that the rodent placenta is not like a human placenta at all. And so humans seem to have a much tighter placenta that prevents the entry of many substances that we find in rodents. So rodent studies are interesting, but they're not at all consistent with what we find in humans. So, but I still think it's not a good idea to do that. Not a good idea. We have good drugs that work for nausea and vomiting in pregnancy. They're safe, have been studied well, and I don't particularly think cannabis is a good choice. But 15% of mothers think that it is, and so our objective now is to find out, is it really dangerous? Does it really cause problems? But we've got to get past the legal issues so that we can study these things. I mean, I can't even study them in my own state. And so we've got to get past the legal problems so that we can actually get down to study what's going on in these mothers.
You think 15% of mothers are using marijuana?
I don't know. It ranges all the way from 5 to 15%. It's simply we simply don't know. But it is really it's significant. It's significant, particularly as it's become more and more legal around the United States.
Thank you.
Thanks. Yes.
I'm just curious about the end point in the study. How can you be sure that it's no dangerous? I mean, they can cure disease later on in the stage. How old are the kids that you've been looking on in the population?
Yeah, you can never be certain. My job is to find out how much is actually there and how much is actually transmitted via milk and how much is absorbed by the infant. Right now, we have not known that at all. The older studies that were done were simply wrong. And so we did it as pharmacokinetically accurately as we could. We controlled the dose, we controlled the timing, we controlled everything that the mother did so that we knew exactly how much was in breast milk. And it's fortunately not terribly high. I can't say much more than that because this is getting ready to be published and I've been embargoed and I can't say a lot about it. But the good news is heretofore we thought there was massive amount of marijuana in breast milk, and that's simply wrong.
And how big was the population in the study?
2 in that study. It was done in 1984. So quantitatively, I don't think they did it right. But nevertheless.
2 is not a high number for
No,
quantity.
it's not. Not.
Okay. I know the scientific numbers are sometimes different,
Yeah.
but still, okay. Thank you. Other questions? Oh, Karen has a question from an online journalist.
The question is for Professor Azad. The question is, which are your recommendations that you would make for the prophylaxis of asthma? And also, which are the ingredients in the breast milk that are important for the protections against asthma?
Sure, great question. So some of you might know the World Health Organization has a recommendation on breastfeeding, and many individual countries have adopted that recommendation. So that official international recommendation for breastfeeding in general is to exclusively breastfeed, meaning breast milk only, nothing else, until 6 months, and then to continue breastfeeding for up to 2 years and beyond, as long as the mom and baby are comfortable. So what we see in our study is firstly evidence to support that, so longer is more beneficial. But what we also see, and what I think is really important as a message for mums, is that each month counts, or each week counts. Each drop counts, you could say. And so I think that's important because I know that some mums might look at that recommendation and say, 6 months exclusive breastfeeding, I'll never make it, I have to go back to work, or I just can't do it. And so maybe they give up altogether. So I think an important message is that we see that, yes, the babies exclusively breastfed for 6 months have the lowest rates of wheezing and asthma later on. But we also see that if they're exclusively breastfed for 3 months, that's still a benefit compared to no breastfeeding or shorter breastfeeding. So I would support the international recommendation, but I also would say that each week counts. So any amount that a mom can do is beneficial. And that includes partial breastfeeding. If that's all that's possible, then even any breastfeeding is better than none. And then in terms of the ingredients, this is a great question, and it's one that I don't have the final answer to yet because we're still doing that research. But I mentioned a little bit that we're looking at microbes. So we're seeing evidence that the gut bacteria are important for preventing asthma. So other researchers in the child study have found a number of specific bacteria that seem to be missing in the babies who later on go on to develop asthma. And so we're looking at whether those bacteria are maybe coming from milk, or maybe they're fed by the oligosaccharides in the milk. So those are 2 components I'm really interested in, is the microbes and the oligosaccharides. But other things that we're getting ready to start studying include something called cytokines. So these are molecules in milk that alter the immune system. So babies are born essentially with no immune system. It's totally immature. They rely on milk to get antibodies and these cytokines and other factors that help them develop immunity. And asthma is essentially a malfunctioning of the immune system. So those are some of the elements that we're looking at. But I think a key point is that it's probably not one specific ingredient that's important. It's a collection of many of them, because that's what babies receive in milk, is this amazing combination of multiple personalized factors.
That's quite complex to study then, isn't it? Because you have to study the interdynamics of these elements.
It's complex. You mentioned exotic when you started, and I thought, I'd never thought of this as exotic, but it's definitely exciting and complex because it is this huge puzzle, and that's why it takes teams of what I would call multidisciplinary researchers who specialize in these different elements, but having them work together and look at the totality of milk, because I think it's kind of human nature to want to simplify everything and say, what's the one magic ingredient that we need our babies to receive? But it's never that simple.
And you said that you were collecting samples from these mothers, and especially mothers, I guess, with a genetic history of asthma?
Yeah, so that's been one of the key points of our research is we have some mothers in the study that have asthma themselves or have allergies. And what we found was that the breastfeeding was particularly beneficial in moms who had asthma. So their babies are already at higher risk because they have that genetic family history or predisposition to asthma. And it was those babies that seemed to benefit the most from breastfeeding. So perhaps because they were already at that higher risk, if they were breastfed, it really lowered that risk. And I think that might be one reason why, if you look in the literature at other studies, there doesn't seem to be a clear answer that breastfeeding is necessarily beneficial. And I think that's probably because in different studies, you might have had different proportions of women who already had asthma. So if you looked at a study of all women with asthma, you'd probably see a huge effect from breastfeeding. But if you looked at a population of women where nobody had asthma, you might not have seen a huge benefit, but that's because there wasn't much risk to begin with. So these are kind of nuances that are important to address in research. They're important because if you do a study concluding there's no benefit, then that's a message that's probably wrong. So digging a little deeper into these nuances of the population is really important. And I think it gives, it's an important message to give moms with asthma that it's especially important that they breastfeed if they can, because it's going to have a long-lasting benefit for their babies.
Does anyone else have a question now? Yes? Okay.
There's another question coming from the live chat, and the question is for Professor Johnson. Can you give some figures how breastfeeding influences healthcare costs?
Sure. So they're both in full-term infants as well as infants who are in the neonatal intensive care unit. There's a growing body of research that shows the cost benefits. If we look at full-term infants and the benefits for both childhood and adulthood, there's a medical savings due to reducing emergency department visits, hospital stays, and other unnecessary medical care, as well as non-medical cost savings associated with the caregiver, the parent, not having to attend to those medical needs. It really depends on the chronic disease that we're looking at, whether it is lower respiratory infection, acute otitis media. The cost savings from a medical and non-medical perspective vary. If we look at the neonatal intensive care unit and the effective dose and duration of human milk or mother's own milk for very low birth weight and premature infants, the cost savings are much more immediate. Dr. Meyer was talking about reducing the risk for chronic conditions such as bronchopulmonary dysplasia or chronic lung disease, necrotizing enteric colitis, late onset sepsis. In U.S. dollars, and I realize the cost translation is going to be less in other countries, but in the United States, those diseases increase the cost in the newborn intensive care unit by up to $40,000 US. So avoiding just one case of one of those morbidities can have a significant impact on the overall initial hospital cost.
Thank you. Do we have another question? Okay, while your minds are working, I'll ask one more question for Professor Azad. I'm curious to know, have you been able to see that the breast milk coming from a mother who had asthma herself is different than the breast milk of a mother who didn't?
Good question. So we will be looking at that. So far, we haven't found that in the microbiome, the microbes in the breast milk. It will be really interesting to see when we start looking at the cytokines and the immune factors, because those are the things you might guess most strongly would be different in mums with asthma. But the reason we looked at that in the first place in the study was to say, is there different effects of breastfeeding in mums with asthma and without? Is because there have been some studies published suggesting that maybe the milk is different in mums who have allergies or asthma, or maybe it's not as beneficial. You see that in the obesity literature too. Maybe milk from obese mums is not as beneficial, or it's too high in calories. And from all the research we're doing, we're not seeing that, at least on the epidemiologic side. So we see that, I also do work in obesity, breastfeeding, whether the mum is obese or not, has a strong benefit for the infant in terms of preventing obesity. And with asthma, whether or not the mum has asthma, we see benefits. In fact, in this case, even more benefits when the mum has asthma. So I think these are important questions, because we want to be very careful about messages getting out that your milk is not good or it's not good enough, because as others have said, the human breast and the human mammary gland and the human system is really intelligent, and we see that milk is pretty personalized for that baby and what it needs. So it's important to ask those specific questions.
Okay, thank you. Other questions?
I have a question to Bruce German. If we're looking in the future with personalized medicine, and you're saying that the milk is adopting, if you're looking 10 or 20 years ahead, how do you see that the nutrition industry and the medical industry is going to develop? How do you see the future about this dynamic milk?
Yeah, actually, we study milk in part to understand nourishment in the broader sense. And milk is teaching us several things, obviously relevant for babies. And there's, I don't think, any question, and this panel will agree, that the lack of support for mothers and babies is a social embarrassment. We have to fix that. So it would be, I think, a much more intensive support system for mothers and babies for the first couple of years minimum. But in general, what is milk teaching us that's going to be valuable for the rest of us is medical research has focused on diseases and their therapeutic cure. And very little has been done on what is prevention and how would you do that. But that's exactly what milk does for mammalian infants. It's a prevention system. And so understanding how we can intervene early, in fact, genuinely prevent multiple diseases is something that milk has been wonderful. The other thing that's really fascinating about milk is you start looking at health differently. So right now, health is a one-tailed test, as we call it. It's disease not. So you have a disease or you don't have a disease, and that's as good as it gets. But milk actually enhances performance in various ways. So you start thinking about what's possible. If I could control my own health, what would I like to be able to do? And if you look across, especially mammalian lactation, milk helps different mammal and mammalian infants to do things that are appropriate for those mammals, but quite spectacular. So I think actually what milk is going to do is change the way we think about our own health, and then it's going to be a very exciting opportunity. What would you like to be able to control?
I have a follow-up question then for you, Professor German. Could you enumerate a little bit on these spectacular things that milk enables you to do?
Okay, well, if we take examples through history, one of the most remarkable mammalian stories is a Canadian one. It's the hooded seal. So the hooded seal is a seal born in the North Atlantic on ice floes, right in the middle of polar bear territory. And a baby seal, of course, is lunch for a polar bear. It's a very hostile environment. And so how does lactation solve that problem? Well, one of the ways it does it is very fast. It only lasts 4 days. But in each of those 4 days, the mother seal transfers through milk to the baby 7 kilos, 15 pounds of fat. At the end of 4 days, that baby seal is 50 pounds in essence, fatter. But what it is it's fuel. Because now the baby seal can jump into the water and go out and swim with all of that fuel for weeks without having to worry about being attacked by polar bears. So it's at the end of the day, it's a fueling system. And so as we begin to understand, okay, what is fueling? It's the delivery of fuel where you want, when you want. And so clearly that's something that milk does for babies. But if we think about that in more, in essence, broad and personal terms, being able to control where your fuel goes when you want. I mean, the example, I get home at the end of the day, tired, kids say, you want to play? Oh, Dad's tired. How about the weekend? Well, imagine that you could actually construct your diet such that when you got home at the end of the day, that's when you felt most energized and wanted to play. So being able to control metabolism and fuel priority is clearly what lactation has gotten right for babies. I'd like to have that too.
So how far away are you from being able to apply that pattern in human milk to a dietary plan for somebody, an adult, let's say? Is that the wrong question?
That's a tantalizing question. And in fact, it's not just metabolism. It's metabolism, it's immunity, it's physiology. Milk works on so many of the infant's complex biological processes. I would say within the next decade, especially for very clinically relevant applications, in for example, controlling the immune system, are very accessible. I personally want to have more energy, so I'm pushing that. But I mean, it's things like mood, it's sleep, it's all the things that we don't really even think about as health now. But if you could control it, you'd love that.
And this is what milk is regulating in the baby.
Absolutely. Yeah, as I say, milk changes constantly according to those particular needs of an infant. Milk is different at the beginning of the feeding and the end of the feeding, the morning and the afternoon. Katie Hind has shown that mothers who have boys make slightly different milk than mothers who have girls. So there's boy milk and girl milk. Oh my gosh. I think I need a boy diet.
Are there any more questions?
I just wonder, how long time do you think that the mother should give milk to the baby then? Do you think that you should prolong the time? Is it 3 years, 4 years? What do you recommend? What do you think that you will recommend in the future?
Yeah, actually, I think some of the studies coming out of Megan's research suggest that exclusive breastfeeding has its time, but then continuing some breastfeeding as complementary foods are introduced, I think that's really important. And I think that what we're going to realize is some human milk over a prolonged period is actually probably very good. And that means that not only does that mean a difference in the way we, in essence, think about milk, sociologically, that's going to mean changes. The history of primates and lactation shows that actually breastfeeding goes on for quite long periods in a more anthropological sense. And actually, humans may not be the longest lactators. The orangutan it has a very long lactation schedule, and anthropologically, it looks like that's necessary because the orangutan feeds on a very complex food web. And so being able to, in essence, consume breast milk for long periods allows the mother to teach her infant how to feed on this particular fruit and vegetable in this month, and another in another month. So the more complicated the lifestyle of primates, the longer lactation helps. It's hard to imagine that wouldn't be good for humans. Just saying.
Yes, please.
So, Bruce, if I could, I just want to add something to that, if you mind. So, I think the analogy for the seal pup is fascinating. And I often use the analogy that what separates the human from other mammals is the brain. And if you look at the fact that postnatally, the human brain grows very rapidly for 2 years, and much of the accumulated substrate in the brain is fat, that I think that you could make the thinking, at least, that the ideal time for some breast milk in the human is through the first 2 years of life. And if you put that from a developmental perspective, that would also coincide with the protection of spacing pregnancies for lactational amenorrhea, I think that there's good evidence from what milk is meant to do for the human, not just the baby, but the mother, that we could likely say that the ideal time would be at least 2 years. So I don't know if you want to, but I think that what separates the human is the brain. And the milk compared to other mammalian milk, for example, the seal pup being such high fat, the milk that the human is making is very, very low protein as compared to other mammals. In fact, it's the lowest protein in the entire mammalian kingdom because protein is associated with rapid early weight gain. And when milk is high protein in a human, the infant gains weight too rapidly, and that becomes its own catalyst for rapid weight gain thereafter. So the idea of a low protein, because I would argue milk can only do one thing. Well, it prioritizes, like you say. And the priority in the human is that it grows and develops the brain. And in other mammals, the brain is less important than being able to escape from your predators. So you have a higher protein milk so you can develop and be functional quicker. So the milk of the human is meant to supply rapid metabolic fuel for the brain that's very metabolically active and growing, as well as the type of substrate that develops the brain in a very ideal human way. So the milk of a human is really, I think, meant primarily to develop the brain, and as a side effect, because the protein is low, it also has the function of reducing the risk of early rapid weight gain, which is an obesity risk factor.
Mm-hmm. Thank you. Who is the...
Hello?
Oh, good.
Yes, I might ask, maybe to all of you, do you, in terms of looking at the role or the purpose or the function of the man, the male, in terms of lactation and breastfeeding, how, is there more research to be done looking at that role or function from different perspectives? How do you feel about that? I don't know who is best who would like to
I can start. I'm sure many of us have comments there. I think that's a great question. I think it's broader than just breastfeeding and lactation in terms of the role of the dads and the fathers. So studying the developmental origins of disease, a lot of the focus is on the moms. What are the moms doing during pregnancy? How long are they breastfeeding? How can we support the moms? That's all very important. But the fathers play a huge role, and we see that from many elements. And I know of a group in Australia who are developing an app, so a phone app for your smartphone. It's called the Milkman, and it's an app specifically geared to dads to teach them about the benefits of breastfeeding and human milk and how they can support their partners in breastfeeding. And they've got some interesting data around the effectiveness of that. I think they make it almost like a game. You can get points for helping your partner support breastfeeding. Yeah. Donna might know more about it. But I think it's really important. I've actually just come from a visit with a cohort study in England. The babies in this study were born in 1991, so they're not babies anymore. And I was digging through all the amazing questions and data that this study has collected. And one of the things I'm really excited to analyze, because they asked the questions and then kind of forgot about the information. No one's ever looked at it. But they asked all the fathers in the study a series of questions about breastfeeding and what they thought about it, whether it was important, whether it was inconvenient. And they asked the same question of the mothers. So there's been a lot of evidence around mothers' perceptions and intentions around breastfeeding and how that translates to what they actually do. But I think it's going to be very interesting to see how much it matters what the fathers think, and my guess would be that it's important. So that will be forthcoming.
So that app is very popular. in Perth. And we know the researchers doing that, and I said to them, I hope you're giving the men points for doing the dishes and cooking the meals, because part of it is not to encourage men to feed the baby, but to be the support group. There is anthropological research of Lee Gettler's where he talks about not the dyad but the triad. And so there are physiological hormonal changes in the father as the breastfeeding occurs. And that has an impact for protection of the mother and the infant. And we do know from studies that men are very powerful in encouraging breastfeeding and also encouraging ceasing breastfeeding. So having men support women along that journey is incredibly important, and that's why it's really good to see some research in that. And I think it's in Germany, because they drink a lot of beer, right? Somebody did a study and they had the men meet in the tavern to talk about breastfeeding, and it was highly successful. So bringing the whole population on board with human lactation will be much more successful than just targeting the mother, because every single person in this world is touched by breast milk.
Well said. So grill parties for breastfeeding.
I would, to answer your question as well, in terms of translating this evidence to a newborn intensive care unit environment, I had mentioned before that our primary people who provide direct care for lactation for the families in the newborn intensive care unit are former parents. And I had a male breastfeeding peer counselor in a part of that role for a 2-year period of time. So he was a direct lactation care provider, and his focus was directly working with the fathers on what they should be doing to support lactation in the mothers who had babies in intensive care.
And how much success did you have there?
It was phenomenal. I'm from Chicago, and he was in all the newspapers. He was on television because he had such a strong message about the fact that it wasn't just for the mother, that this as a father is what you can do. And certainly in newborn intensive care unit, parents often feel so very helpless because the baby's early, the baby's sick, and having someone to be able to model for you, this is what a father does in those situations, or this is what a mother does, was very, very helpful. So it's, again, a way of translating basic research about what a father does and putting it into a clinical setting.
Well, and could I just add, from the economic perspective, one of the biggest costs of breastfeeding isn't free. One of the biggest costs is the mom's opportunity cost, or the value of her time spent in breastfeeding. So the father can reduce that opportunity cost by, as Donna was alluding to, taking on some of the other duties to reduce the productivity loss for the mom. And the lower that opportunity cost, the longer the mom is likely to continue breastfeeding.
Storm? Yes.
Il y a un dernier élément de réponse sur le...
There's a last answer on the role of the father. When we talk about the importance of these 1,000 days from the time of fertilization until the age of 2, we talk about the environment for the mother and the child. And there's a lot of research that makes us believe that the environment, the few weeks preceding fertilization, is very important. So therefore, the environment of the father and the mother during the few weeks before fertilization, that is very important for the future and the future health. And here the involvement of the father is very important.
Of, newspapers, and you never know if it's true or not, but I read that it's possible to restart a woman that has been breastfeeding to start again. And since the society is moving on, and if you are lesbian, can you both go ahead and breastfeed your baby, and how do you do it?
Fascinating question.
I guess I can take that one on. Yes, because certainly in newborn intensive care unit, we've had a number of opportunities for mothers that, for example, initially made the decision they were not going to breastfeed their babies, and then the baby has a complication, and the mother decides 2 months later she wants to lactate, or a mother who's never breastfed. So the strategy for this would be that a mother would usually begin to stimulate the breast using a breast pump. And then at the same time, some sort of pharmacologic augmentation to that. I would let Tom probably speak to that, but something that would be the stimulation of the mammary gland, and then something that would be a lactation inducer, which I would think you would recommend the domperidone. I've had experience doing this as well. My experience personally is that the mother who has never lactated will not make a full milk supply, but will make some milk for her baby so that she can still breastfeed. And then to the extent the mother wants to, and let's say it's a lesbian couple, one of the mother is making more of the milk than the other, the natural birth mother. So the other birth mother could feed the baby at the breast and then it's a little pouch called a supplementer. So the baby can get milk at the same time from this little pouch that the baby's feeding at the other mother's breast. So there are all types of possibilities. But there are some mothers, I have worked with some mothers who have been able to relactate. So they have lactated, they've stopped, and then we start them. And typically it is the period of time between the stopping and the starting for those mothers. And if they've had a good milk supply, and then they stop, and then 2 months later they want to start, it's much more successful than a mother who would be 12 months or 15 months. Do you want to add to that?
Generally, pharmacologically, to induce new lactation, the approach is try to mimic the environment used when the mother becomes pregnant early on. So we use high doses of progestins and high doses of estrogens to induce that state for a few months, and then we start inducing the levels of prolactin. And primarily, the way we do that is a drug called domperidone. And domperidone causes the release of prolactin from the pituitary. So you have high doses of estrogen, high doses of prolactin, and that starts the synthesis of milk in the breast. Then with adequate pumping, then you can get at least a partial milk supply. And it's not always a robust milk supply, as Paul has talked about, but you can get some.
Wow. An equalizer. That's fantastic. Yes. Can you pass that down, please? Thank you.
Bonjour, Estelle Synthèse du magazine Parents.
I come from the Parent magazine. Now, if you look at all the advantages, the undeniable advantages of human lactation on health, I always wonder why in France, but also elsewhere in the world, health professionals are not more involved in supporting human lactation. Because what we've observed in France is that indeed there is help in the hospitals, etc., clinics, but there's a lot of bad advice and a lot of professionals who are not well informed. So there's a lack of support. And we're wondering why there aren't teams dedicated to supporting breastfeeding in all the maternities or all the neonatal ICUs. In France, it is very different from one place to another, and we're really wondering about this. We need emotional support. And as you said earlier on, in France, it is often mothers who are volunteers who will go and help women so that they succeed in this breastfeeding. And I find that a bit strange.
there's really a global issue with mothers getting inconsistent information, despite the fact that there are a lot of data available. And one of the big concerns on the part of healthcare providers, if you read this literature, is that it's so often looked at as a personal decision that they do not feel that they should influence. So that the mothers are told it's a personal choice, or the physician might say, we recommend that you breastfeed. And the mother might say, but I don't think I'll make enough milk, or I tried before and it didn't work. So that the response to that is usually not so much one of, well, this time we're going to make it happen because. So I think that there is a lot of lack of understanding. There is a huge amount of scientific literature about the outcomes of human milk or breastfeeding for babies. But there are still wide groups of professionals that refuse to read it, or they will simply say, I don't believe it, which is very frustrating because coming from the NICU, for example, that would be to say, well, I don't believe in antibiotics, or I don't believe in the respirator, just because I don't believe in it. You could never do that, but people do that about mother's own milk because it's not looked at as essential. So I think that that's a part of what we are experiencing, is that people don't know the answers. The other thing I would add, and I'll turn it over to Tom, is we talk about investment in promotion of breastfeeding. There's a lot more investment typically in promotion than what we would call protection. And that's the mother who's having problems. So the mother who says, I started breastfeeding, but I had sore nipples, or the baby wouldn't latch onto the breast. The support infrastructure for that in terms of paid available help is really not existent in many, many places. And it's like you said, it varies so much with the institution and the geography. So it's often thought of as long as we tell mothers how important breastfeeding is, then that's all we need to do. But there really must be an investment in the infrastructure to help the mothers solve those common problems. And that's what I think is the missing part. It's a misallocation of where those dollars should go.
I work in a medical school environment. I train medical students and residents every single day. And medicine as a field has grown enormously in the last 50 years. It is so enormous, you can't know everything. And so in the medical field, we've started to subspecialize. We have oncologists, we have all pediatric infectious disease. We have all different kinds of subspecialty because the field is just so enormous. And because of that enormity, breastfeeding has really not fit in well there. And the way we do it now is people like us here try to push this into our medical students so that the medical students can learn these sorts of things. But it's difficult. It's very difficult because they have to get ready for boards. They have to pass. They have to enter residency programs. They have to do so many things that involve hardcore medicine that breastfeeding just kind of falls away as an aside. And so it's been that way for the last 50 years, and I think it's probably getting a little bit worse, perhaps. But we try to do as much as we can. Each year I have my pediatric residents come spend 4 hours, and I have breastfeeding mothers there so they can actually see a baby latch on. They've never seen that before. And so we actually try to incorporate that as much as we can. But it's a sad fact that it just, as far as importance in the field of medicine, it's not developed that importance that infectious disease or oncology or psychiatry or surgery has approached in the last 50 years. It's just a sad fact, but that's reality. It's reality.
I wanted to just add, I think kind of the irony or what's really sad about that is breastfeeding is important to oncology. It prevents breast cancer. It's important to psychiatry. It supports mental health in moms. It's important to each of those fields, not just pediatrics, which is where people might think it fits best. So I think it's really an important priority that we get lactation science into medical school in the basic curriculum. There's a researcher I know of in Canada, in Ottawa, named Dr. Catherine Pound, and she's a clinician herself, and she's been developing some education modules that are now being built into, I think it's residency training programs for medical trainees in Canada, to teach them about why is breastfeeding important, and very importantly, how to support a mom who's having issues. Because what she found in some of her earlier work, which was really just to survey healthcare professionals and ask them what they know about breastfeeding and how comfortable they were in supporting moms, is that they were really uncomfortable, and they didn't even want to ask a mom with a new baby how breastfeeding was going, because if she said she was having a problem, they didn't know how to help. So that's a really big red flag. And so she's now working on programs to help train medical care providers in how to support moms and to understand that it's important. I had an experience, so I'm not a medical doctor, I'm a PhD scientist, but we had a great speaker in at the University of Manitoba. She gave a talk about the importance of breastfeeding. There were many clinical people in the audience, and one of them raised her hand, and she was a general care provider, so a GP, and she said, "Wow, that's amazing. I do tell my patients to breastfeed, but I just tell them to do it because it's free," which even isn't true, "and it saves money. I didn't know it had all these effects." And I just thought, like, what? This is a doctor that doesn't know this stuff, and she's the doctor that came to this talk about breastfeeding. What about all the other doctors that didn't even care enough to come to this talk? So that was like an aha moment for me, and it made me think about what do we need to do to nip this in the bud and make sure it's not just doctors, it's all of society. Because as we've talked about, we need everyone on board to support breastfeeding. We need dads, and we need just kids in the street to not look funny at a mom who's breastfeeding on a park bench. So everyone should know this. So I have a new project looking at how we teach kids about breastfeeding in school. And the first finding is we don't teach them much. So figuring out where it might fit in, and that doesn't need to be just teaching. We actually, in Manitoba, we teach teenage girls mainly, a small fraction of them. So if they choose to take a course called Family Studies towards the end of high school, they might learn a little bit about breastfeeding. But firstly, not everyone takes that course. Secondly, no boys take that course. So like that's not the people we need to be teaching. So we want to look at, can we teach little kids in kindergarten before they sort of get into the whole sexualization of breasts and all those issues. Just teach them that this is how babies eat. And so they can grow up knowing that's normal, whether they go into medical school or some other profession. So I think that's really important. Sorry, that was a long answer.
Not at all. Thank you. Professor Storm.
Oui, il y a effectivement pour
Yes, to rebound on the questions you were putting earlier on, there's a lot of heterogeneity from one maternity to another, especially in France, and the breastfeeding rates in France are not very good. What is posing problem in the field is the heterogeneous knowledge between all the caregivers, the doctors, etc., different investments, and the fact that you train a small group of people, lactation consultants, for example, that's not enough. We see it on the field. It's not enough because the messages are different in one single maternity itself. And so to have labeled programs like hospitals, friends of babies, I think that's the best way to harmonize this program. And knowledge on this training. Everybody has to sign a charter so that they receive basic knowledge on all this. And the messages disseminated are not different. And there are some experts, of course, but globally everybody has the same level. And in this maternity, IHAB, well, we have breastfeeding rates that are quite high. So the hospital baby's friend was a very good initiative. Mothers have found out that in these maternities, it's good to give birth to your babies there because they have good advice on breastfeeding. So I think maternities should be motivated to be part of these programs. Now, in France, there's one university maternity, but now it's being disseminated in more maternities, and things are going to change. And in my region, Hauts-de-France, all the maternities in the Hauts-de-France region are going to be part of this program.
Could I just quickly add to that? I think one of the major problems is that people don't understand how these benefits are being transmitted to the infant, to the mother, in terms of lower breast cancer risk, in terms of lower risk of diabetes. How is the breast fundamentally changing during this process that's actually leading to these benefits? And I think by understanding that, by understanding what's happening in the breast, which is what we're trying to look at, I think that's going to give us a lot more information to help encourage a whole different population of people to support breastfeeding. So for me, I think understanding the how is very important as well.
I think that goes to Paula's point of people saying they don't believe in it. So by understanding the how, it means that they won't be able to not believe it because we'll have the evidence.
I would add one thing because I agree completely with the idea of the baby-friendly hospitals getting mothers off to this good start. But if you look globally, the biggest time for lactation risk is in the first 2 weeks. And that's mothers of full-term babies, mothers of premature babies. And it really is because of the enormous changes going on as the breast transitions from basically getting ready to secrete milk to secreting milk and building an established threshold of milk. And that happens in that first 2 weeks. So that's the period of time that mothers who might have risk factors need to be identified because, just like Donna said, the problem might not be tongue tie. It might be that the mother has a low milk supply. That would be the time mothers have sore nipples, that mothers have breast engorgement. So that short period of time is typically, if you look at the research literature, is what makes or breaks lactation. So even having something that if we were to prioritize resources in terms of economic resources, it would be in that period of time that we really establish a baby at breast or establish a mother's milk supply if she's pumping. And then I think the others could be additive, but if we really looked at the period of time, it's that first 2 weeks.
And if I could add to that, part of our scientific basic program is to develop measures for mothers that are high risk. So they go to a doctor and a doctor can prescribe an antibiotic, but do they ever test the milk? No, they don't, despite the evidence there that they can determine what the infection is and prescribe the obvious or the best antibiotic. We can measure milk transfer in the babies very easily. We can't keep this track that breastfeeding is natural for every woman because, as you know, many women struggle with it. So we have to support her not just with the emotional support, but with measures that show her what's happening in her breast. And whether that's all okay or it's not, it's an opportunity to tailor the management to that mother for success. And she can see something that's being done. So I think it's important within the medical system to have all of the resources that's within that system to be used for breastfeeding women, which are currently not. They're not part of that system.
That's interesting. Does anyone have a follow-up question? I do have a follow-up question, because you're talking about the training of medical staff all around the world, right? And how, aside from the research that's coming that will explain much more about how things work to try to persuade people, is there a way to create a standardized program and say, look, this is part of your standard curriculum. You must learn this minimum amount if you're going to be working with mothers and babies. Is that a tall order?
Well, in a medical school, that's very difficult to do because every minute of their time is scheduled, it seems, and to get anything new in there is kind of difficult. I just do it randomly when some other professor in my department doesn't want to lecture that day, I go do it. So that's the way I do it. But to get it in a standardized program in a medical school would take a major effort. to do.
I think I can add to that. Our medical students do receive some training simply because we do lactation research within the university. So if we can pour more money into research in universities, then by default the researchers will start teaching the medical profession. So it becomes a more attractive subject in their curriculum because you have experts that are looking at the basic pathology or the epidemiology or that kind of thing. A stealth mode, perhaps.
I'm sorry. I would just add to that too, because I will pick up on what Megan said, because there is a trend now both in nursing and in medicine in terms of even textbooks and education to not have a single hour class on breastfeeding within maternity, but instead to integrate the science of human milk and lactation throughout the curriculum. So when you learn about metabolic diseases, you learn about the role of breast milk in protecting that or reducing the risk of those. So I do think that there's a trend in this. It's certainly something that I think in both nursing and medicine we're aware of. And we're focusing much more on what we would call this interdisciplinary education for much of this so that the people learn at the same time with each other. And less about this hour about how to put a baby to breast and more for the physicians about how to think about human milk as a primary prevention behavior.
So breaking down the silos between these specialties, is that?
Breaking down the silos, and I think the other thing that that I'm trying to say is that it isn't just about teaching you how to put a baby onto the breast. It's teaching you how to think about breastfeeding within an overall lifetime of health. So as you learn as a physician, as Tom is saying, they learn about oncology, they learn about metabolic diseases, is that breastfeeding and the role of breast milk is put into all of those things. You read about, okay, well, these are the risk factors for this diabetes. And then in there is going to be something about not having been breastfed. So I think that increasingly what we're seeing is a move towards, especially with the physician education, with this integration, as well as with nursing. And I think much of that is what I call interdisciplinary, in that they learn in the same course some of these fundamental things. So it's not a course. You can certainly do courses on breastfeeding and lactation if this is going to be your primary specialty, but integrating the scientific content so you don't end up with, well, I don't believe it's important. You know, if you've been exposed to how it reduces the risks of all of these other complications, then you know it's important. You may not know how to do it yourself, but you're not going to say it doesn't matter.
If there's one area of medicine that's really attuned to breastfeeding, it's neonatal medicine. The neonatal units around the world are real hotbeds of breastfeeding right now. And it's because, as Paula said, that we now recognize that the difference between life and death in a premature infant is whether or not they breastfeed. It's just that certain. I mean, a 14-fold reduction in necrotizing enterocolitis, just if you breastfeed that baby, is major. And so in our neonatal intensive care unit, we do lots of lactation education, and we talk about it, and the students get some review about lactation. So neonatal units are really a good place to do this because it is really, really important there.
Thank you. Well, we are nearing the end, so I want to give anybody who still has an open question the opportunity. Good. This may be the last question, and then there'll be one-on-one interviews with the journalists who are still here.
So briefly, do you feel that the World Health Organization need to update their guidelines on breastfeeding? In what areas? And do you feel that politicians in different states of the world might be able to adopt and implement those guidelines in a better way or different way than they do today? Is this important or not for the
So one comment I would have on that is I've met someone from the WHO who's sort of in charge of all this programming, and I know that they are consistently reevaluating the evidence and looking at whether there needs to be updates, which is a wonderful thing. I think one area that might require an update is the period for exclusive breastfeeding. So right now it's at 6 months, and there's some evidence behind that. That's how they made the decision. But there's some intriguing evidence from the allergy field in particular about when is the best time to start introducing foods, and specifically foods that are common allergenic foods. So peanut is one good example. The evidence is starting to show that maybe introducing those foods in small amounts earlier might help prevent allergies. But if you do that, it goes against the WHO guideline. So for example, if you wanted to introduce peanuts at 5 months, then that means your baby's not only receiving breast milk. So I think that's an area of active research right now. We're going to be looking at that in the child study. And so maybe it's not the addition of these foods, but rather the replacement of breast milk that's important for all of these other outcomes. So I think that's one area that requires some more research. And maybe others have comments on that.
Actually, I think one of the things that's going to change is more strict recommendations of how complementary foods are introduced. And Megan brings this up. There's a big difference between exclusively breastfeeding for 6 months and then one day, boom, everything changes, versus gradually adding smaller amounts of complementary foods on a background of breastfeeding. From an immunological perspective, this is completely different, and yet it's not really treated in the guidelines. And so I think you're going to see guidelines be more, in essence, prescriptive about how you begin to introduce complementary foods.
Recommendations right now are sort of one size fits all. It's the same recommendation for everyone, but maybe it should be different depending on your genetic background of history of allergy. And one thing that even the newest studies haven't addressed, but I think is really fascinating, is what is the mom eating? So when you talk about allergies and introducing foods, we know that proteins or little pieces of the foods the mom's eating, including peanuts, get into the breast milk. So that's one way that the baby's getting exposed. And some of our early data show that that's probably really important to consider too. So.
And both on a different line, both the governments and employers supporting longer paid maternity time can reduce the economic barriers or facilitate longer-term breastfeeding, which from an economic perspective is key.
Interesting.
Il y a sûrement aussi à côté.
And also, on top of the WHO guidelines, there's also regulation in each of the countries. We see that the differences are coming from the rules, especially when it comes to parental leave, for example. If we could have a longer maternity leave, certainly mothers would breastfeed their children for a longer period. And also the logistics is important. When a mom goes back to work, she has to have access to a breastfeeding room where she can pump her milk to feed her baby in the evening. You know, all those things have to also be implemented in the countries, and it's only the evolution of policies that will allow this to happen.
On that note, I think we'll say thank you so much to all of you for sharing a wealth of knowledge already in this press conference. And this is not to mention 45-minute presentations coming from each speaker in the course of the symposium. So now we're going to wrap up the press conference. I would like to invite the journalists to talk to the speakers. And thank you also for making yourselves available for that. From now until, let's say, 11:30 or 12, you have the opportunity to ask the speakers questions one-on-one. So thank you all so much for your attention. I wish you a wonderful time here and lots of information.